While people are doing that, we're just encouraging everyone to type in the chat where they're calling in from. I'll just go to the next slide. So we are welcoming and honoring a very important guest, Elder TK from the territory Guasala Naquado. And I'll hand it over to Alexa and Elder TK to open this up in a good way.
All right, so TK did do a little bit of an opening prayer, but maybe TK, if you want to share a couple words about helping our vulnerable folks in the community that struggle with either alcohol use disorder or substance use disorder.
My name is Tommy Henderson, and I carry the name of my great grandfather. My nephew and I both have the same name, EIDGE. It means the right maker, or making things right. We're from Illicit to Doctoral. Corrina is north to us. We pretty much speak the same language. And we were happy where we originated from. But now we're stuck here on this rock. And being stuck here, our youth and young people are in town to strengthen whatever they can. And I can go sit with them and talk to them about what I went through, and they don't believe me. That's how young they are. And the oldest of that three started crying, and then the rest pulled up and started crying. And I cried with them. You don't know any of their history. You don't know if they have an Indian name that was given to them when they were born. They can't speak our language. So while they were going to school way back when the cultural program wasn't happening yet, but it is now. And I'm trying to teach our young ones what's the right path to take, and not to do what you see in town. We love them; they're all our relatives, all of them. But once you get into the alcohol and it's stuck, you lose all sense of whom you are, your identity, where you come from, what does life mean to you, things like that. And we have a great team that works out of the clinic here, and I love them for the strength they have to help our people in the best way they can. And I take great pride in them. Every nurse we have is working with us and for us. So when I say it's a great team, it certainly is. That a lot of the work they do is behind the scenes, but we know they're doing it, and they're a godsend. Every one of them gets right out. So I pretty much drank myself to this. Over 50 years of drinking. And I didn't know who I was when I sobered up. I didn't look down there, I didn't have my friends, relatives. That's how lonely I got. And I signed myself into a treatment center. Came out 30 days later, it didn't work. I was back more drinking habit. So that was a waste of somebody's money that was trying to help me. And then the second time that I got sent away because I was going crazy. I was 30 days in a mental institution, and 30 days in alcohol program at Pawnmakers Lodge. I was there for 30 days. When I came out of that one, that's when it hit me. What is it? Where have I been? Where am I going? Who am I? And start weeping that. Because I was so lonely, there's nobody around. And there was a reason for that. I was beating people up, ended up in jail. But I stood up for my wife and I will try our best to help our people. She looked my nephew, his family. She said, yeah, for him and his wife are into everything, trying to help our misplaced or homeless, whatever you want to call it, poor people. They don't have a place to live because what they just came out of is this place up. I'm pretty sure there was 18 of them that came following out the door, taking pictures of them. That's how many on the rancher. So all this girl ended up in town. So she had no privacy and there to eat because of her numbers. Now stuck in town, drinking all the time. But she wants to put an oil cabin or people up and try and help them find their identity, who they are, their history. That's something they really need to know and know that they're loved by people. But they're not wrong. Others are thinking the same thing. But I'm grateful to be here to share what I went through and how much I love my family and try and help as best I can. So I thank whoever put this together. I thank them from the bottom of my heart. It's reawakening our spirits and stand at our council fire and look to see whom we are and how we can best help our people. Yes, yeah, we can watch me.
Thank you so much, Elder TK, for those very powerful, impactful words. And we're so grateful that you can be here to start us off and ground us in a really good way. I am just going to speak to a few housekeeping notes for everyone who's on the call. So we are setting an intention for this webinar, and Elder TK really set us in the intention, and we're here to support each other, to support community members, and really help each other in times when often people are like what we've been talking about is really in the triple pandemic of a substance use crisis, the COVID-19 crisis, and also the crisis of racism in healthcare. So our intention is to be here as a collective together to really address some of those points, and also hopefully we can bring home some tangible actions and ways we can move forward together. This webinar is being recorded, just so everyone's aware, and everyone is on mute, so no need to worry about that. We will have a Q&A session at the end of the meeting, so feel free to type questions in the chat after for any of our panelists. And also, to keep this engaged, you can type your questions in the chat as we move through the presentation, and Corrina and I will be watching the chat box while the other presenters are presenting. So if you're just new to Zoom, this is where the chat box is located. You click on the chat icon and it will come up, or it's to the left, to the right of your screen. Just when you're typing in the chat, make sure if you're wanting everyone to see the chat that it says to everyone. And if you're just wanting the panelists to see a question or make a comment to the panelists, you can just select the panelists as well. If you're having trouble seeing the slides at all, you can adjust your view options. That is located in the red box you can see, and you can try and sort out any way to see the slides or the speakers that might be better for your Zoom screen. There are some annotate options, which I don't think we're using in this slide. We're using chat and poll questions, so I'll just skip through that. And please, if the reaction button's available, feel free to give us a clap, a thumbs up. I know we're speaking about some really heavy topics today, but if there's something you really agree with, feel free to chime in as well if you can. And you can also change how you see the speakers as well. So that's just with the speaker view. We don't have everyone's photos video, which is new for us. So you won't be able to use the gallery view, but feel free to ask the panelists if you're having any technology issues. We do acknowledge that this is heavy content. We are speaking about the health and well-being of people and how alcohol is really creating some harms in communities. So if you need, please feel free to step away, take a breath, reach out. And this is the number to the QS crisis line if you're needing some support. You can also feel free to reach out to the panelists on the webinar as well. Now I get to, with lots of excitement, introduce this wonderful panelist. We have such a wealth of expertise. So we'll just do a round table in order on the slide. And if each panelist could introduce themselves and where they're calling from, that would be great.
Hi, good afternoon, everyone. My name is Corrina Chase, and I'm the First Nations Addictions Care Partnership Manager. And I'm really honored to be here with you and this amazing team to do this work. Thank you.
Hey everyone, my name is Alexa Biza, and I'm the team lead and an RN for the BCCSU Managed Alcohol Program. Got a couple of people sitting with me today. Gotta say your name, Jessie.
I'm Jessie Howardson. I'm an RN. I work with Alexa with the Managed Alcohol Program.
And we do have TK, and we also have Daryl, who's one of our NEMIMA workers, and also a council member that has been part of the conversation since the beginning of GMAPS.
Hi, everyone. My name's Meaghan Brown. I am a settler nurse and doctoral candidate research coordinator on the Canadian Managed Alcohol Program study here at the Canadian Institute for Substance Use Research at the University of Victoria, which is on the unceded and traditional territory of the Wakangan-speaking peoples and the Saanich peoples. Yeah, I've worked in managed alcohol for the past 7 years. I have some clinical experience in a residential managed alcohol program in Ontario and one here in BC. So I'm super excited to be here having this conversation. I feel like it's been in talks for years. So thank you so much for being here today.
Hi, I'm Brittany Graham. I'm the Community of Practice Coordinator for the Canadian Managed Alcohol Program Study. And I also work at the Vancouver Area Network of Drug Users with their drinkers group called the Eastside Illicit Drinkers Group for Education. So I'm located on the unceded territories of the Musqueam, Tsleil-Waututh, and Squamish nations, which excited to be here. Yeah, I'm similar to Meaghan, been working with MAP related stuff for a while, and I think maybe a few people on this call are part of the community of practice, so might be used to my face or my voice or my emails. So excited to be here and have this conversation, because I think it's really a great place to start the conversation. Thanks for having me.
Thank you to all you facilitators. And my name is Kate Hodgson. I am a settler that's calling in gratitude from the traditional ancestral territory of Tla'amin Nation. I do work for FNHA as a nursing practice consultant for substance use, and I will be your facilitator today. these are our 3 learning objectives for today. So we hope we can move through them. If you have any questions or you're feeling like you need some clarity, please feel free to type in the chat. Also feel free to leave your email address if you want us to get in touch with you after the webinar. So first, we're going to speak a little bit about stigma and how that relates to alcohol use in First Nation communities. Then the GMAPS program is going to demonstrate how their remote community in BC did address alcohol-related harms by providing managed alcohol programs. And then we're going to hear from leading experts as to how to implement evidence-based MAPS programs based on the examples and the organizations that they have been working with.
Oh, hi, everyone. So we're going to start off with an activity. If everyone can go over to the chat box and start typing in some labels or negative language that really impacts people who use alcohol. Yes, alcoholic, boozer. Yes. Clean versus unclean, yes. So the reasons why we're talking about this, I'm trying to click the slide. I can't click the next slide. Is we're talking about destigmatizing language. And we know that stigma is a prevailing barrier for people who drink, and even people to access medications for alcohol use seems to be a huge barrier. People find it really uncomfortable to be talking about it with physicians for fear of judgment and other issues that will come up in their personal life as a result of that. Next slide, please. So we're going to talk about the types of stigma. So, okay, thanks, Kate. Yeah, we missed that one. Stigma is marked as a sign of disgrace. And I often think, like, I really want to try to tie in somebody that you know personally, or that somebody in your family, or possibly even yourself if you talk about alcohol use disorder. And for me, it's my uncle who passed away from alcohol use disorder. And I think about some of the impacts that he lived with and why he wasn't accessing healthcare. And so for sure, alcoholism, especially upon Indigenous people, is this mark of shame. And it's so embedded within our social society that I think it's such a hard barrier to come across and really kind of face those really hateful words and judgment. And it imposes such a deep shame that it's really extremely hard to break through that in order to access help. So lots of times people feel isolated and so shameful that they don't even fit into society as a result of their use. And they're treated like that. With the old moral model, we know that some of the judgments from the moral model still come forward today in people's narrative. And the town drunk, or you know, that's the person who lost their family and they live on the street and they're the bum. And we know that those things, in order for them to be positive change and positive outcomes, we want them to be able to trust the system. So we have to actually change about how, not only us, but the people at our dinner table and how we interact with their family, and what kind of messaging do we send them about this. Jungle bunny. Yeah, that's another, like, I feel like there's so many ways for stigma to impact people. Next slide, please. So the types of stigma. So we have structural stigma, systemic stigma. So the policies that are barriers for people in accessing harm reduction supplies. Social stigma is negative attitudes towards people who use alcohol or drugs with friends and family members. And once again, the whole social stigma is a huge issue for people who want to access harm reduction. If I don't feel safe in talking to my friends and family about it, how am I going to feel safe in talking to a stranger at the desk where I'm accessing care? And or if it's a family doctor that I know, that might even be a further barrier just because of the more shame. The issues is these stigmas happen simultaneously. So I'm self-stigmatizing myself. I feel shameful. Somebody else is impacting me with their thoughts and process about how I should be. And then the systemic stigma is this. So with a compilation of stigma, it's, I think those are drivers to make people even want to medicate more, feel like they're unworthy, and causing further barriers. So next slide, please. The drivers of stigma. Stigma is often delivered by stereotypes, and negative perceptions translate into negative attitudes and reinforce other people to do those behaviors. The legacy of colonization, lots of language, culture has significantly impacted why people do medicate. Often the person experiences the stigma simultaneously, and I think we just talked a little bit about that, but next slide, please. All right, so substance use disorder, and we're talking about a lot about decolonizing substance use and how do we do that? And the idea is really to take out paternalistic language, to be really prescriptive in how we support people in their own pathway to wellness. And if people want to drink, why aren't we supporting them with that? If we're funneling out other medications that don't always support people in what they want to do, how is that helpful? How are we supporting people in that self-determination? And we know why these things have happened because of loss of land, loss of culture, loss of language. Next slide, please. So the problem with experiencing loss of land, loss of culture, loss of identity, loss of language, which is so huge, people experience trauma. And we know the residential schools, the 60s impact, and losing the land has greatly caused devastation amongst First Nations people. So the thing is for connection and bringing people together for healing. And the way that we can do that is listening to them in their journey and supporting them of what they want for their pathway. Decolonizing alcohol is talk about what happened in ways that remove the blame and the labeling for people, and understand these social issues are being severed from people accessing their culture, their language, their land, and their family. So when we come together to support them with culture, with connection, with love, then we can support them on their pathway. Next slide.
Thanks, Corrina. So as many of us know, the In Plain Sight report came out earlier this year, and unfortunately, really the impetus of this report was around stereotypes and stigma related to alcohol use, specifically directed towards Indigenous people. So this review found that extensive profiling of Indigenous patients based on stereotypes of addiction. This really highlights how far we need to come and how important these conversations and really naming what is going on in our healthcare system and social systems and what's happening. This report, in plain sight, is intended to explore the stigma and discrimination experienced by Indigenous people in the healthcare system and to make recommendations that will help eliminate Indigenous-specific racism and create substantive equity in healthcare experiences, services, and outcomes. This slide is a really great representation of breaking the cycle model and recommendations. And what that means is that substantive equity in healthcare and outcomes for Indigenous people need to adequately address the legacy of colonization that Corrina just spoke about. In healthcare and truly uphold Indigenous human rights, reduce harms, and improve quality of life. What substantive equity means, which is in the top right corner of the slide there, is the requirements to achieve equality, opportunities, and outcomes, and is advanced through equal access, equal opportunity, and the provision of services and benefits in a manner and according to the standards that meet the unique needs and circumstances of cultural, social, economic, and historical disadvantage. An opportunity, the provision of services and benefits in a manner and according to the standards that meet any meet the unique needs of Indigenous people. So in the case of MAPS, it is a promising programmatic response to care. And this affirms that these programs need to be self-determined, contextualized responses that privilege Indigenous knowledge, such as land-based healing, culture as medicine, language, ceremonies, and connection to elders that Corrina and Elder TK have spoken about. So with that, it is truly everyone's responsibility, and that's where everyone everyone on this call comes into play, that we all are responsible for reducing racism, calling out racism, discrimination, stigma, in order to improve the health and well-being of Indigenous people. So I would like to hand it over to Alexa and Jesse to speak about their experiences and their program.
All right, just going to share my screen. I've got a kind of short PowerPoint. There we go. Is everyone able to see the PowerPoint? I'm just going to assume yes. All right, thanks guys. So like I said before, my name is Alexa. I'm the team lead on the program. We were also going to have Kathy Wilson, one of our outreach workers, join us today, but she's got a medical. Thanks, Tim. That was Tim, just our office manager. So we're currently calling in from the on Silkwater Reserve, so Whistle and Nakokto communities, and this is technically a traditional Kwagilk territory. So Whistle and Nakokto communities were forcefully moved here in 1964 by the feds, so they are unfortunately not living on their own land right now. They're living on essentially what is a displaced territory. So we also do have today with us Daryl, who's one of the council members that was involved from the start in getting these conversations going about harm reduction in community. And I will have him kind of talk about that in a little bit, but just to preface it, so we are a community-based outreach managed alcohol program. So we see folks that are either on reserve or on reserve, whether they're Indigenous or non-Indigenous. We see folks from other nations as well. So we've got Boggled folks on the program. We've got folks from Hodgson, the neighboring communities, folks from GNN as well. And then we do have Indigenous folks that are not attached to nations around Port Hardy on the program, as well as non-Indigenous peoples. The program that we have right now is the 2 RNs and 2 outreach workers, and we do operate 7 days a week, 8:30 till 6:30. We started off almost, well, it will soon be a year ago, but the conversation started last May when COVID-19 hit. And it had a lot to do about the community going into lockdown, and then some pretty dangerous or potentially dangerous things happening to community members. So when that rolled out, we were having daily talks between the health team and the elected chief and council, as well as weekly or even a couple times a week conversations with elected chief and council and hereditary chiefs and matriarchs to try to develop plans for both COVID-19, but also to try to lessen harms to folks living on reserve and off reserve from GNM. So I will kind of pass the proverbial mic over to Daryl. He wants to talk about his experience of being on council when we had those first discussions. Go for it, Daryl.
Good afternoon, Gail Kessler. Welcome. Just want to thank Alexa for asking to come on and share some of the stuff that was asked by not only the chief and council, but the community of the Wasilla Nakado. I guess it started, some of the stuff with the COVID and some of the stuff that happened, within our nation, which included, when we had pretty much a lockdown in our community. So there's only one way in, and that's through a bridge into our community. So there was at the time, the COVID lockdown was something very new to our people, and accessing the alcohol was a daily thing, whether it's a young man or an older lady, that was a daily routine for our people. And then having a lockdown that it really just basically just shut the world down, and it came to the point where our people were to avoid the bridge, we had kind of strict guidelines and policies as to where you're going, how long you're going for, so on and so forth. And just came to the point where some of our people, whether it's 5 in the morning or 8 o'clock in the evening, that they would skip or not come through the access on the bridge, but they would actually go upriver and cross the river up the ways there. And there's actually one point we had to go and look for a couple that then late evening, dark out, they lost their way, and we spent 3 or 4 hours looking for them because they didn't want to come across the bridge because they had the alcohol on them. So that whole stigma, right, of you're thinking that they're going to be judged and ridiculed and so on and so forth. So they took it upon themselves to go up river and cross in an area that was pretty treacherous. We actually had to call Campbell River Search and Rescue to come up and give us a hand. So just those things that come into play. Also, just where we're going as a nation. This MAPS program is something that was asked by leadership, hereditary chiefs or matriarchs. Just on better taking better care of our community members, so we don't have an incident like that. Where we could have potentially lost a couple of young people because of the alcohol addictions that they had, and how scared they were just to cross our bridge and go to town and grab their alcohol and come back. Trying to sidestep that policy. So it was just something that the nation was very concerned about, and leadership really took it to heart that it could have been a situation that would have fell on chief council's table or on our hands, and not looking after our people. like I said, going back to the COVID time, having a lockdown. So, it's a program that has been well taken by not only First Nations, but I think the District of Fort Hardy. We're pretty impressed on the initiative that we took, as First Nations. So it's a program that I think it's can only get bigger and better with the support of everybody around that, really, takes a look at, what the MAPS program is all about. The other people that are on the list, whether it's our nation or our friends and family of the Quaggy, or friends and family of the Luskamuk Nation, and some of the urbanites that, don't live in our reservations. That's funny to say reservations. I was just at a meeting this morning, talking about the plight of our people having to be, like Alexa has mentioned a few minutes ago, about our nation, the Wasanaka, are actually, situated on the Quaggy traditional territories. So, it's kind of hard, go back to that word stigma. That was a very tough one for our people too, walking in town and, being looked at, told that you guys are intruders on our territory, go back to the mainland as well. You know what, it wasn't our ask, it wasn't our doing, it was, came from the provincial and federal government that, relocated our nation to where we are today. Over time we've had to fight and struggle. The struggle is real. And, the alcoholism, was a major factor on, our way of life. And it's just something that we are working very hard on turning around. We can talk about the healing center that we have. We're working very hard on getting that going, and that's in our traditional waters of the Guasala and Aquadot. That it's a land-based, ocean-based center that I think will really turn our people around once that's up and running. And I think MAPS is just a starting point of turning that around for the addictions of alcohol for a lot of our members. And it's not just strictly GNN members. We're opening the door for other nations that would want to come and come to our healing center. And I think that's about it. I probably could share more, but I love to talk. And so once again, thank you for this. And I just want to thank Alexa and Jesse for the invite. And I just hope that this program will have a huge impact on a lot of First Nations, and so we can turn it around. That just go back to that stigma, being alcoholics, and that was never us. Alcohol was introduced to us by the
white people.
By the white people, the Mamakla, in our language, the Mamakla. So we are strong-willed, and we are resilient, and we will overcome that one day. Gaelic Custom.
Thanks, Daryl. So yeah, I'll just, I guess, take a couple more minutes. I know that we're already kind of flying over time here, but essentially just to say that that's our origins were like, it didn't take a lot of time necessarily to have the initial conversations. As soon as it was kind of demonstrated that there was very clear risks to community members, the conversations surrounding harm reduction were, both elected leadership and hereditary leadership were quickly on board. It was very much a question of, once we got the funding, and the funding came from FNHA very quickly. That funding was for 2 positions, which was just a nurse and an outreach worker. So once we got started in August doing our drops, we were working 5 days a week. Soon realized that it couldn't only be 5 days a week. Folks were having like so much success during the week in seeing reduction or management of their alcohol consumption, and then everything would turn to chaos for the weekends. So we pushed quite strongly to Island Health to match the monetary contributions that FNHA put forward. And once we got that, we were able to hire another RN and an outreach worker. So we're doing 7 days a week now. We have about 10 clients that we see currently. Of those 10 clients, we see everyone once to twice a day, but most often twice a day. And then there's always room currently for kind of more short-term COVID-19 intake. So if there is someone that is suffering from alcohol use disorder and needs to isolate and go on kind of a short-term MAP. Otherwise, we provide harm reduction services as well in terms of, you know, if someone needs clean needles or they need clean pipes, that type of thing, naloxone trainings. We do medication management for all of our folks as well. Get them hooked up with family doctors, often for the first time, or workups that they've been, they haven't been able to follow up on for whatever the length of time is. And also ensuring that if they want, they can have access to mental health services, both from GNN or from our partners with the Island Health Mental Health and Substance Use Team. And it was really a question of, you know, once we had a physician champion the managed alcohol program for the rural hospital and family clinic up here, it was pretty easy in that they were able to have some conversations with their peers and get on board. So we are definitely able to go to all the physicians in Port Hardy at this point if one of our folks needs support or, you know, consulting for a prescribed alcohol dose. And yeah, that's kind of the origin story. So it happened pretty spontaneously. If you still have access to COVID-19 funding, it is definitely pretty easy to slide a little managed alcohol program in there. But it's definitely something I think that can be born fairly spontaneously. And then once the kind of the roots are there, it's pretty, you know, it's not groundbreaking or anything to be able to have a program that maintains itself over time. So yeah, that's it for us. Thanks, guys.
Alexa, I think there's one question directed for your team, which is, and Burl, feel free to correct me, but for your MAPS program, do you provide services to any nations outside of Gwakwino territory from around BC, or is it just Vancouver Island region only?
So for our team, we are at the very northern tip of Vancouver Island. So we can only provide services to folks that we can access by car within like a reasonable amount of time. We see most of our clients are quite high needs. So let's say the town of Port McNeill, which is about a 35-minute drive away, would be too far. But most of the folks that we are able to see have to be within, you know, 15 minutes of Port Hardy, regardless of which way you go. So, you know, we're always happy to have conversations with people that want to start managed alcohol programs elsewhere and kind of just like how we did it, or some, you know, ideas, even if it's just a motivational speech or something to get folks going, because all you really need is one champion. But as far as the reach of our program, it's pretty local because we physically go to every drop several times a day. So people have to be reasonably close.
Great. There was 2 more follow-up questions, Alexa. What about your land-based healing center? Is that going to be open to other territory or regions?
Yeah, so the land-based healing center is, I mean, some of it is technically on land, but it's also like territorial waterways, right? So it's actually going to be a floating healing center. There was a float house that was donated to the community, so we're in the process of renovating it, and there's going to be there's a lot of plans for it, nothing concrete yet, and that the build hasn't been officialized. Plus, with COVID, it's kind of hard to start residential type healing programs. But once that's out of the way and the build is finished, it'll be good to go. I think that you know, at first, anyways, it's likely that GNN members will have priority, but I think as once we're able to work through or work with some of the folks that from community that are interested, then it will slowly and progressively become more open, and that we do want it to be a long-term thing. So it once it gets to that point, it'll be, I think, advertised as such.
And one final question is, do all clients on the MAPS program require physician orders for alcohol dosing?
So it's something that we kind of, so in BC, and we have come to learn this, essentially, we definitely start off the program not realizing that nurses could essentially manage alcohol doses in BC. And we start off with like every kind of physician writing a alcohol prescription. Most of the time I will write it and they will sign it. Don't tell anyone. But it's kind of in that it's not this isn't necessarily like a controlled substance, it's a legal substance. A lot of it is titrating up or down on a daily basis or on a every couple day basis. Some folks in that their use fluctuates quite a bit. So depending on what their needs are, either, you know, mentally or physically that day. So the in BC, there is no actual, I guess, legal need. It is within a nurse's scope to manage an alcohol prescription, shall we say, because at the end of the day, the client's able to like purchase their own alcohol and decide how much that they want to drink. So being part of a managed alcohol program is that the client is buying into a managed alcohol plan. So you help manage the plan. We still have an initial meeting with a doctor as a consultant, but also to, you know, for a lot of the folks that we get into the program want to be on medications to help with their cravings for alcohol or for other substances. So it's definitely part of the conversation. So the physician is still kind of on board from a consult purpose, also to have that meet and greet. So if the client has some type of health crisis, then they're able to be attached to a physician at that point. And what we have also found is that a lot of the folks we're intaking have really poor medication compliance for some pretty important medications, whether they're cardiac meds, diabetes meds, whether they want to get started on anti-anxiety meds. So we're taking that on and working with the physician for those items as well.
Thank you so much. We'll hand it over to Meaghan and Brittany.
Hi, everyone. Sorry, I was no video earlier. We have very crappy internet at VANDU, so it's easier to see presentations when I'm off camera. I'm just going to close my door quickly while we set up. Hi. The multitasking of jobs, eh, everybody? So I'm going to start off the beginning of the presentation and then Meaghan's going to take over. So maybe I'll just do my intro now and then Meaghan can do hers when she comes on. Does that sound fine for people? Yeah, so Meaghan's going to kind of push us through this presentation, but I'm Brittany. I already did a hi, hello before. So, and we're here with the Canadian Institute on Substance Use Research from UVic and the Canadian Managed Alcohol Program Study. So that's CMAPS, and you can check out cmaps.ca if you want more information. Meaghan, you can keep going forward. This is just a slide of all the people that were funding us in the past 10 years. So that's really helpful. If you want to see that, you know, you can look at it some other time. So we like to give a brief history on how MAPS came about, because I think it's really interesting. And Alexa's description of what's happened with the GMAP is very similar to what's happened across Canada, as people see an issue that's happening in their community around alcohol use and the stigma, et cetera, and then figure out a program that fits their community. And what we've seen is that, you know, a huge proportion of people who who are homeless have higher severe alcohol dependency. And we can keep going, sorry. Yeah, and so, as we were talking about before, the context of racism and colonization and stigma, everything that's related to alcohol kind of influences how people drink and even how managed alcohol programs come together. Next slide. So here's a really good example of it is the alcohol-related harms. Alcohol is not good for your body when you drink it. Your body doesn't like it. So there are harms that come from that, but also those harms can be seen in another way too. So there's the acute, the chronic, and social. And a lot of these things come from alcohol in and of themselves, but as well, it can come from the stigma that people experience, barriers to getting into social housing or finances, etc., because you're a person that drinks happens just as much as your drinking causing issues with those social problems. So MAPS are really important for that. Why alcohol harm reduction? I think Corrina's introduction was really great. There's lots of reasons that people drink, and I think quite often when people are drinking, they might be using for coping mechanisms or for fun or whatever, but if people don't have safe access to alcohol and they're quite dependent on it, they're going to continue to access alcohol no matter what. So whether that's non-beverage alcohol like Ruby, Listerine, etc., to keep themselves safe and away from things like DTs or seizures, that happens quite often. There's also really unsafe patterns of drinking where people will drink extreme amounts of alcohol and black out or brown out and not really realize where they are and get hurt in the process of that, which is really not great for the person. And the other side of it is when they don't have access to their alcohol, there can be those withdrawals that are really dangerous for folks, like seizures or delirium, and that can be quite harmful to the person and even can cause death in some cases. And then as well, when people are stigmatized with drinking, quite often they can't drink in their homes or their shelters or other places. And so they end up drinking outside, and there's more violence and injury and exposure related to that. So having alcohol harm reductions to help people in these moments and not have these harms is really important. Next slide. So this is an example of a program that started in Toronto. It was in the mid-80s. There were, I think, 3 people who died that winter, and when they did an inquiry related to it, they found that their deaths were directly related to exposure, and that they didn't go into the shelter because they either wanted to keep their alcohol on them or they were too drunk and couldn't go into the shelter. So that kind of started a conversation in Toronto at Seton House about how they could support people who drink alcohol. And through that, a managed alcohol program was created where people were allowed to bring in their alcohol and keep it there, and they would give it to them on an hourly basis based on the time then. Excuse me. Parched. Yeah, so, there's a lot of different types of shelters and housing programs out there, and how people's alcohol use associates with those programs is quite different. So some of those programs allow people to keep their alcohol on them. Some of them won't let them have it. Some places are, what we would call a wet shelter, where you can keep your alcohol there, but not necessarily with you. And some are full-on managed alcohol programs where you can get your alcohol, drink it on premise, and continue to be a part of the program. So, the way the program is set up can really impact the way that someone is able to access resources. Yeah, and so I think until this study started, which was about 10 years ago, MAPS were pretty much under the radar, as this shows, is that we didn't really, I don't think they were really communicating with each other. There was a couple that were well known, but in general, people were doing their own thing in their own communities. So yeah, that's quite interesting. So you can see here, through the last 10 years, we've actually identified a bunch of MAPS that have started since the study started about 10 years ago, but also there are some here that have been around for even longer than Seton House, like Urban Manor, that started in 1985. So there's a long history of managed alcohol programs in Canada, which is really cool. We've identified over 20 pre-COVID, and since COVID, there has been a significant increase in the amount of managed alcohol programs. So what is a MAP? It's a harm reduction program that offers regularly dispensed or administered sources of beverage alcohol alongside accommodation or other programming. So like, that's the basic definition. I think in general, it's a place where somebody can get access alcohol, and that can be decided on the context of the organization. If there's housing, is there not, is it outreach, etc. But the goal is to help that person manage how they're drinking and kind of disperse it throughout the day. So it's very dependent on what the person's goals are and what the program's structure is. So typically MAPs are eligible to people who have had a history of binge drinking, higher levels of consumption, and potentially have had non-beverage alcohol use. So Listerine, rubbing alcohol, and other things that are typically not recommended to be drank. Or could be homeless, quite often are, you know, intoxicated in the public because of the harms we spoke about earlier. You know, and have tried other treatment options and they're just not right for them. Yeah, and quite often if people have higher use of the police or emergency health services, these types of programs are recommended for them. Oh, next slide. Sorry, I might have a delay on my end. So these are the sort of things, the pillars or benchmarks of a MAP that most MAPs would have. So there's, you know, an alcohol intervention. So where people are receiving alcohol at some sort of dosage throughout the day. There are really intense ones where it's every hour, hour and a half. And then there are more less intense ones where people receive their alcohol for the morning or for the day, and that person is monitored throughout the day and they self-administer their alcohol. Quite often there's housing interventions, but there are programs that are day programs that support people who are in other housing. As well, there's usually health and social services attached. So I think Alexa really mentioned it earlier that in BC that nurses can help administer the prescription or prescribing of alcohol, but there are examples of MAPs in throughout Canada and BC that are not medical based, they're community based, and then they usually have some sort of health service attached to that program to help their members, because quite often people don't have access to healthcare, and it's just a good place to get people into the system and getting, you know, checked out for everything that they need. As well, quite a few programs have culture-based strategies or programming, and so it really depends on the type of program. But there are quite a few programs in BC and across Canada that are either peer-led or Indigenous-led, and so they create programming that is important to the membership of that MAP. So some examples here are like elder support programming or drumming. We also have examples of brew co-ops where people help make the alcohol. So it's really dependent on the program itself. So yeah, I think I mentioned this previously, that there are examples of brew co-ops. So quite often programs, if they have the capacity, will brew alcohol on site because it is mildly cheaper than if you're buying it from BC Liquor. I don't think we're aware of any programs that currently have like a license where they get a discount on their alcohol. So you'd be paying full price for that alcohol through BC Liquor or whichever place you're coming from. Quite often they brew it themselves or have a U brew, and there's usually some sort of system in which that funding source is coming from either a health authority, as Alexa mentioned, or as the people are paying into it, as well as Alexa mentioned. I think it's different for each program. I think there's not a lot of permanent supports and funding around managed alcohol programs. So there is a lot of creativity with MAPS around who pays for what and where that can come from. But I do know that quite often when it's a residential program, they'll use people's rent, and part of that would go towards their alcohol consumption, but they would pay part of it. So there's always ways to work it out depending on your program. Yeah, I think this is your turn now, Meg.
Yeah, sorry, I'm just gonna unmute myself and then restart it again.
Okay, I can see my face like 9 times right now. It's great.
Okay. 1 second. Sorry, everyone. I think I clicked the wrong one. Yeah, I did click the wrong show, so I'm happy that I went back. Okay. All right. So I gave a little bit of intro to myself. My name's Meaghan Brown. I have worked on this study since 2015, along with Brittany, as I started as a master's student in research assistant and been on it for a while now. I should acknowledge that the research is led by Dr. Bernie Pauly and Dr. Tim Stockwell. And so we're a pretty interdisciplinary team that have worked with programs across Canada through the Canadian Managed Alcohol Program Study Community of Practice. And so what I'm sharing today is really much based on years of teamwork, really over the past 9 to 10 years. So I'm going to try my best to give you the highlights over the next 10 minutes. So the Canadian Managed Alcohol Program Study is a mixed method study, and its purpose is to evaluate managed alcohol programs across Canada with a focus on implementation and outcomes. We want to understand what's the process of implementing MAP, as well as how well do they work or not work. So some of the questions that we've asked are, do MAPs reduce consumption? Do they reduce alcohol-related harms? Do they improve people's housing stability, their health and quality of life, and economic costs as well? And I should acknowledge that the majority of managed alcohol programs in Canada, as well as our research, are Western-based. So the framework that we're using, or the model that we're using to look at whether MAPs are successful or not, are based within harm reduction and a Western lens of health. But with that, we also are we've worked with 2 Indigenous-led managed alcohol programs in Canada that actually don't define themselves as managed alcohol programs, define themselves more specifically as Indigenous-led healing programs in which Indigenous knowledge and tradition drives support, and alcohol harm reduction can be one part of that. So we can maybe speak a little bit later about some of the work we're doing with the Aboriginal Polish Dead Homelessness here on Lekwungen and Saanich territory to develop an Indigenous evaluation framework and to support in any way we can through our knowledge to develop an Indigenous-led alcohol harm reduction service that's grounded within a local healing support and approaches. So I'll talk a little bit about some of the outcomes that we've seen from looking at about 8+ programs in Canada. Most of them are housing or shelter-based. So again, the BC Managed Alcohol Program is an example of something different, an outreach program, which we've seen spring up more during COVID. And I should also mention, I think it was on one of the slides, that the majority of programs that we've looked at are also based in urban settings. But we are now, I think, starting to learn a bit more about rural approaches. So before I get started into the numbers, I think it's important to just outline the foundation of MAPS, and which are really fundamentally about building trust, community, and support for people who have often been, left out of systems of support in the past. We do have a very abstinence-based treatment and healthcare system. So in our research, we basically had more conversational interviews with participants in MAPS. We basically give them the floor and tell us what they think about them. And people often describe programs as their family and their homes. And so they describe them as being safer than in hospitals and shelters. And they describe their life before entering MAP often as being in a cycle of displacement and stigma, where they don't really have one safe place where they feel comfortable to be able to start to make changes in their life. MAPS become a supportive place where people can start to find their ground. And often people, once they feel that, people care about them and they're not going to judge them for their drinking, they start to think about bigger goals and bigger changes that maybe they never would have thought they would have been able to come back to. And so we have a lot of examples through our research with people is where they've told us that, over a few months or years, they've been able to stabilize in their drinking enough so that they're safe, but so that they can also connect again with their family or their community, which in some cases they may not have been able to see in years. So I'll go over some of the numbers here. So we originally did pilot studies, this is before I started, on two managed alcohol programs. One was Thunder Bay, the Quakey Wind, which was based in a shelter, Thunder Bay House. And all participants in that program were Indigenous, so there were aspects of culturally based support in that program as well. And then the Vancouver Station Street program, which I believe was supported by Vancouver Coastal Health. So what we've seen through both studies with Vancouver and Thunder Bay and the early studies is that participants in both studies, when we compared people who were on MAP and who were off MAP, people on MAP seemed to maintain their housing longer, and they reported increased safety as well. When we looked at alcohol-related harm, so Brittany talked a little bit about those in terms of physical harms and social harms. We saw that over time, or when we looked from when people first entered the program to 6 months later, people on MAP, when compared to people off of MAP, were reporting reduced seizures, reduced housing-related harms, reduced legal harms, and reduced problems in their home life as well. People also reported that they were more satisfied with their housing, so we would look at things like the overall quality of their housing, their privacy, the affordability of their housing. This was specifically in Thunder Bay. And as I said before, people often before coming to MAP talk about a cycle of displacement where they're often picked up by police. They may be in and out of jail. They may be in the emergency department. They may experience a lot of stigma, discrimination, and racism, and never be offered really any type of support. So what we found is that through MAP, over time, people seem to be reducing their police contacts as well as reducing the amount of time that they were spending in hospital and in the emergency department. And this is kind of a story behind how some of those things happen. So this person talks about, having to feel mouthwash because they were at risk of withdrawal, so kind of being in that survival mode where people don't really necessarily have restrictions in their choices, right? So with that, there may be associations with, being in more contact with police because people are forced to make decisions about, their safety in terms of access to alcohol when they can't afford it, or when, for example, many times people may have their alcohol stolen as well. So through that, with a stable supply of alcohol and a safe supply of alcohol, people told us that they've had reduced interactions with police as well. And when we looked at the Thunder Bay program as well, we saw that there was an economic savings. So a lot of this probably having to do with reductions in service use, around $1.09 to $1.21 for every dollar invested in a managed alcohol program. We don't have a lot of time, so I'm not going to go over these in detail, but this was data not from the pilot study, but from looking at 5 MAPs across Canada. So we have a pretty decent sample size there. So you'll see we have 109 people who are long-term on MAP over 2 months in the program, 65 people less than 2 months, and 189 people called control in the research world, which isn't a great name, but those refer to people who are not on managed alcohol, but who have similar levels of consumption. So what we see here is that we see people reducing their non-beverage alcohol use over time, reducing the number of drinks that they have per day. But what we saw is that people who are on the MAP long-term are drinking more days per month, and people off MAP are drinking less days per month, which makes sense because often when people are homeless, they're going through a cycle of binge withdrawal. So at the beginning of the month, having access to money to buy alcohol, binging that, and then near the end of the month, going through withdrawal, and often ending up in and out of jail and hospital during that time. And so when we also looked at some of those harms that I talked about, we saw decreases over time. So these stars indicate ones that were particularly statistically significant. So reductions in harms related to physical health, seizures, assaults, less people reporting that they've passed out in the last 30 days when we asked them. And then reductions in some of these social harms as well. And then when we also looked at over time, over 12 months, we saw people were reporting fewer drinks per day. As time went on, both people on MAP and off MAP were reducing the amount of drinks they had per month. And both groups reduced in their non-beverage alcohol consumption. Again, we continue to see reductions in harm. And like I said, more drinking days per month, but less per day. So it's a more stable pattern of drinking rather than a binge withdrawal pattern. In more recent research we've done has seen improved liver function at 6 months. So when we see people leaving MAP, when we follow them on MAP and off MAP, we saw that their liver function would deteriorate off MAP. And I think I spoke to these here. I'm not going to go I'm not going to go over all the points here. I put this here so that those who refer to slides could see the specific papers where these claims are coming from. They're not just coming out of my brain. So here's some of our backup documentation if you want to take a look. I don't know how much time we have now, so I think I'll just say a couple things. So essentially, these are the core elements that we've looked at in terms of effective managed alcohol programs, and these are unpublished. I would encourage you, if you are interested in learning about, implementation of MAP in your community, we can share a document that we made at the beginning of COVID, which was around upscaling managed alcohol programs rapidly. So we talked to these 4 pillars here in that document. I don't think I need to talk much about MAP and COVID. I think Alexa and her team have talked a lot about how alcohol-related harms were exacerbated during COVID and how that has prompted a need for alcohol harm reduction even more than we've seen in the past. With that, you may also be aware of BCCSU's and ours. We created together with the province of the risk mitigation guideline. And so this includes guidance on managed alcohol. And so from that have been models of managed alcohol similar to the CMAPS that have been recommended. So this is something we could share with you as well. And so as we move forward into the future of managed alcohol programs, we're seeing a changing landscape. So COVID has really started conversations in communities. And I think is maybe a reason why we're here on our phone call today. So we're seeing more questions from rural and remote managed alcohol programs, particularly how to provide alcohol harm reduction services when you don't have a brick and mortar MAP. And there's also some questions about, you know, how do we provide MAP as a COVID emergency response versus a long-term alcohol harm reduction program. And so this is our website here, and we'll share that as well. When you go to this website, you can go to scroll down, and all of our publications from this study are there. And that's it. Thank you very much.
Thank you so much to our excellent presenters. Thanks, Alexa and team. Corrina and I had prepared a few poll questions. So we're gonna hope that this works. And if are the poll questions gonna come up, Corrina?
Yes.
Great.
Do you see them right now?
We see them. So if you're still on the call, if you're able to answer the poll, that would be great. Great. I think we'll close off the poll there. Is that?
So we're talking about our poll. Is this your first time attending or learning about MAPS? We have 22% at yes and 78% at no. Number 2 is MAPS. Is this something you are considering to support in your community? 73% said yes and 2% said no and 24% said maybe. Number 3, is stigma a barrier in your community for people to feel safe about accessing harm reduction? 78% said yes, 11% said no, and 11% said unsure. So thank you all for participating.
Thank you. And we had one question from someone, which was for Alexa and team, which is wanting to know what is a typical example of one dose? If someone is using a 12-pack a day, where do you start?
So it really depends on, well, a 12-pack of what, but also what that 12-pack would get them. So if I have someone that coming on to the program has worked really, really, really hard to get down to 12 beers a day, but I'm not gonna cut them down further if like they're already at their minimum daily dose to prevent them from getting withdrawal symptoms. There's a lot of people that drink a lot of alcohol, and so they require a pretty high starting dose, and it's still going to be a reduction. So it depends on the client, it depends on what effect they're getting from the alcohol that they're drinking right now and how safe they feel in reducing. It's kind of, I think that the number that they kind of give, or that most physicians will look at is kind of aiming for a 20% maximum reduction if they're going from kind of an amount that they are actively drinking, but that they're still getting like a lot of intoxication from. So if I'm drinking, I don't know, 10 beers daily, and it's 5.5%, that I'm making sure that, you know, in the prescription that the client's going to get, it's still going to be that 5.5, and we might start off at 8. If 8 is something that they're comfortable with and that they're not getting severely intoxicated from. If I have someone being intaked into the program that is drinking to the point of blacking out on a daily basis, then that's a different discussion. So it really depends. Most folks that struggle with severe alcohol use disorder have been drinking for a very long time, and they know how much it takes for them to not go into withdrawal. So most folks are able to acknowledge a minimum amount that they need. So even if, like, let's say the bare minimum will kind of do 20% more than that to start off, so if they're comfortable, they're able to actually work within a reduction. If you, I mean, there's obviously dangers to, and like physiological risks to cutting too quickly, but it also, I think, would affect the success of them wanting to stay on the program if you're like going too far at it. And it really depends on their goals as well, right? You don't want to give too much and that they're severely intoxicated, but you also want them to feel comfortable with the dose that they're getting. If this is just someone that wants to continue drinking, but in a more managed way, then you find a dose that they're happy with and that you're happy with. And if this is someone that does have intent on actually cutting down over time, then you're working from a different goal point. So yeah, it really depends on the client and what they're drinking.
Great, thanks. And is Elder TK available to close us in a good way?
Yes. TK, do you want to close us?
Sure, it gives one good feeling that help is starting to happen with our lost souls in town. And it's terrible to remind them of those that have passed away in those areas where we drink. Found this frozen, others died in their sleep. And I'll have to get the numbers and remind those that are still drinking. You could end up like this, and this is what we don't want. So I stand really proud of all those that are helping their nations and the ones that are here. And I send everyone lots of love. And I'll close with the prayer that my grandfather often shared with chief with all of us. Knowledge of Creator in our language. That they have used words skip the faith. They have taken a book and now, and that is what access to the Nakwa and passing this ourselves is the allow us to all the gifts and closing of the after. I said, put us to put us. There's all the stuff of the stuff of Nala. There's this stuff and the call of the world, said, what is what I say that no whole Western. Yeah, this for the Nala. Yeah, that's the you you. Thank you.
Thanks, TK.
Thank you so much to our panelists, and thank you to the audience. That closes our presentation for today.